With syndromes of adrenal insufficiency covered, the logical next step is to discuss adrenal hyperfunction, of course. And keeping with the theme here, this is a journey towards the center of the adrenal. Spoiler alert, we're actually not going to make it to the very center. That's the medulla, which is responsible for secreting epinephrine in response to sympathetic stimuli. We're saving that gem for our next sketch. Today, we're just scratching the surface, working our way through the cortex of the adrenal, starting with the outermost layer and working our way inward, with lots of suspense and excitement and hormone hyperfunction every step of the way. Time to dig. The outermost layer of the adrenal cortex is the zona glomerulosa, where the mineralocorticoid hormone aldosterone lurks. Normally, its synthesis is stimulated by the renin-angiotensin cascade. Once released into the serum, aldosterone goes to work at the distal nephron, promoting sodium and therefore volume retention by the kidney. Gaze in astonishment upon those giant mineralocorticoid mineral crystals. Mother flippin' huge, right? So what's causing all this aldosterone activity? Well, this isn't a renin problem or an angiotensin problem. It's the adrenal cortex itself that's gone haywire. Hypersecretion of aldosterone due to an intrinsic pathology of the adrenal gland is dubbed primary hyperaldosteronism. By far, the two most common causes of primary hyperaldosteronism are an aldosterone-secreting adenoma and an idiopathic disorder aptly named bilateral idiopathic hyperaldosteronism. Let's start with the idiopathic one. Because no matter how perilous the journey or dire the circumstances, it's never an inopportune time to pull off the old idiot sign on the back gag. Oh, man. Textbook execution right there. So, bilateral idiopathic hyperaldosteronism is, in fact, idiopathic, as in, we don't really understand the pathogenesis. Nonetheless, it's responsible for about 60 to 70% of cases of primary hyperaldosteronism, most commonly in children and young adults. This disorder is also referred to as bilateral idiopathic adrenal hyperplasia. So pay attention to those hats. They're not only bilateral, but pretty big for their heads, wouldn't you say? Hyperplastic, even? What does this look like under the microscope? Well, the zona glomerulosa is the outermost cellular layer of the adrenal gland, right up against the renal capsule, featuring cells arranged in clusters or arches. Turns out that, in the setting of bilateral idiopathic hyperaldosteronism, the cells actually look pretty normal. It's just that there are too many of them. The hyperplasia can be diffuse or focal, and it appears in both glands. All right, if it's not an idiopathic bilateral hyperplasia of the glands, then it's probably an aldosterone-secreting adenoma hiding out in the cortex, which accounts for 30 to 40% of primary hyperaldosteronism cases. Aldosterone-producing adrenal adenomas are most commonly unilateral, solitary, small, usually less than 2 centimeters, and well circumscribed, with a bright yellow appearance from lipid in the cortical cells. The ad in adenoma is symbolized by the plus sign on our next explorer's adrenal cap. Think of that light as a small, solitary, well-circumscribed tumor sitting in the gland. And because it's a functional tumor that secretes hormone, we're turning the light on. A characteristic feature in aldosterone adenomas is the presence of eosinophilic cytoplasmic inclusion bodies called spironolactone bodies, depicted by the pink spots decorating that spironolactone spiral notebook. Spironolactone bodies usually appear after treatment with hydrochlorothiazide. Nah, just kidding. These are seen after spironolactone treatment. You should have seen the look on your face, though. Spironolactone acts as an aldosterone antagonist and is the drug of choice for managing primary hyperaldosteronism. Now, all this aldosterone getting secreted by the adenoma does not exert negative feedback onto the pituitary, which means that adrenocorticotropic hormone, or ACTH, release will persist. Therefore, do not expect to see atrophy of the contralateral adrenal gland. As we'll show in just a bit, an adenoma that secretes cortisol will, in fact, shut down the pituitary, causing the contralateral adrenal to lose ACTH stimulation and undergo atrophy. To finish off our list, a few more rare causes of primary hyperaldosteronism include carcinoma of the adrenal gland, as well as ectopic aldosterone-secreting tumors, which can occur in the kidney or ovaries. So look around you. We have all these mineralocorticoids floating around the circulation. What is this going to do to the body? Well, recall that aldosterone upregulates the sodium-potassium pumps in the distal tubule and collecting ducts of the nephron, which promotes sodium reabsorption and potassium excretion by the kidney. Let's start with that sodium. Remember, at the distal nephron, sodium retention means volume retention. This results in the most significant effect of excess aldosterone, hypertension, represented by that high-pressure geyser. Hyperaldosteronism is a pretty common cause of secondary hypertension, actually. Secondary meaning that we actually know what's driving the increase in blood pressure. Hypertension in primary hyperaldosteronism tends to be severe stage 2 hypertension, with most cases presenting with systolic pressures around 160 to 180 and diastolic pressures over 100. This may also present as so-called resistant hypertension, which means that blood pressure is not adequately controlled with 3 or more antihypertensive meds. Hypokalemia may or may not be present, though it is a classically described lab finding, and by that I mean highly tested on your exams in step 1, mostly because it highlights the expected aldosterone physiology. At the distal nephron, aldosterone activates basolateral sodium-potassium pumps, bringing sodium into the body and kicking potassium out into the urine, as illustrated by those falling potassium bananas. Hypokalemia is usually not too significant, unless some other factor is added that contributes to potassium loss. In severe cases, hypokalemia can cause muscle weakness and cardiac arrhythmias. Check out our fluid and electrolytes unit for way more info. Hypokalemia goes hand in hand with metabolic alkalosis, by the way. A few mechanisms are probably at work here. Hypokalemia activates potassium-hydrogen exchange at the collecting duct, which promotes potassium reabsorption and acid excretion. Additionally, aldosterone itself acts at the collecting duct to activate H+ ATPases, which further enhances urinary acid excretion. And thirdly, hypokalemia in the extracellular compartment causes an electrolyte shift. Potassium moves out of cells, while sodium and hydrogen ions move inside. In the nephron, when H+ moves into the tubular cells, this actually causes an intracellular acidosis, and the cells respond by increasing acid excretion and bicarb reabsorption. Yeah, it's complicated. Check out our potassium sketch in the fluid and electrolytes unit if you want to hear it all over again, just with chimps instead of humans. At Sketchy, acidosis is usually represented with a yellowish acid-like substance, while alkalosis is depicted by a bluish alkaline mineral pool, kinda recreating the colors of a litmus test, if you will. While there can be pronounced hypernatremia and volume overload at first, most patients with primary hyperaldosteronism achieve a normal to mildly elevated sodium and only slightly elevated volume status. This is an important distinction, because secondary causes of hyperaldosteronism, like CHF or cirrhosis, are often characterized by volume overload and edema. Primary hyperaldosteronism patients, on the other hand, avoid this fate via the cleverly named aldosterone escape mechanism, which is illustrated up on the escaping airship. When primary hyperaldosteronism first develops, sodium and water retention lead to volume overload and hypertension, just like that overloaded steam engine tank. This has 2 primary effects. First, the increased blood pressure leads to increased renal blood flow and enhanced glomerular filtration, or GFR. Increased GFR allows the kidneys to process more sodium and excrete some of the excess, a process aptly described as pressure natriuresis. Just think of the peanuts in water up there, falling overboard as the ship receives a surge of pressure. Also, you see how those inflated balloons at the back of the ship resemble 2 stretched atria? Volume overload activates stretch receptors in the atrium, which release the natriuretic peptide AMP. These molecules go to work at the renal collecting duct, further increasing sodium and water excretion. A balance between sodium and water retention versus excretion is usually reached, minimizing volume overload. This leads to a steady state of mild hypervolemia. But this is enough to cause chronic hypertension. Remember, without this escape mechanism, hypervolemia would be much worse, with lots of edema and stuff. We'll see this in secondary causes of hyperaldosteronism. Diagnosis of primary hyperaldosteronism starts with measuring the plasma aldosterone concentration and the plasma renin activity. As you'd expect, the aldosterone concentration is high. No trick question there. So what do you think the renin activity will be? High or low? It all goes back to the juxtaglomerular cells of the glomerulus. They normally secrete renin in response to a drop in blood pressure. So when blood pressure is high, as in primary hyperaldosteronism, expect plasma renin to be low. To confirm the diagnosis, a salt suppression test is performed. The patient is given salt supplements for several days, which, in a healthy individual, should suppress the renin-angiotensin-aldosterone axis. Because, aldosterone is all about sodium conservation, not the most useful hormone when you're forced to eat over 6 grams of salt per day. Well, if at the end of the test, urine aldosterone levels are still high, diagnosis of primary hyperaldosteronism is in the can. No pun intended. Yeah, actually, intended. Treatment of primary hyperaldosteronism, as with most things, depends on what's causing it. For adenomas, surgical resection is usually curative. Patients with bilateral idiopathic hyperaldosteronism are treated medically, since removing both adrenals would cause a whole other set of problems that we don't want to get into right now. The typical regimen includes a low-sodium diet and spironolactone, an aldosterone antagonist. Regarding the low-sodium diet, it turns out that the hypertension caused by primary aldosteronism is very salt-sensitive. Which kind of makes sense, because the whole reason we have high pressure in the first place is all that sodium and volume retention by the kidney. So give the kidney less salt to work with. That ought to do it. The most feared complications associated with primary hyperaldosteronism stem from the severe hypertension that's difficult to treat and the whole bag of badness that comes with it, including left ventricular hypertrophy, diastolic dysfunction, heart failure, MI, and stroke. All right, that's it for primary. On to secondary. Secondary hyperaldosteronism occurs, you guessed it, secondary to other conditions. Specifically, those that activate aldosterone release a little higher up in the chain of command. The big player here is renin, represented by the airship in the back that resembles a recurring renin rain umbrella. Either because of reduced renal perfusion or a renin-producing tumor, it's time to turn up the entire renin-angiotensin-aldosterone system. Let's start with reduced renal perfusion. This can occur in the setting of certain conditions that are associated with excessive peripheral edema, such as CHF, cirrhosis, and nephrotic syndrome. You see, all that edema means less fluid in the vascular system. The kidney feels this intravascular volume depletion and increases renin secretion, with subsequent activation of the angiotensin-aldosterone cascade. It's a vicious cycle, actually. The more edema you have, the more your intravascular compartment gets depleted, stimulating even more aldosterone release, which causes water conservation and even more edema. You're basically just stuck under a waterfall. Another cause of secondary hyperaldosteronism is renovascular hypertension. This occurs when renal perfusion is decreased by blockage of the renal artery lumen, usually due to atherosclerosis or fibromuscular dysplasia. Just think of those tightly twisted red lines tethering that kidney balloon. As a result of decreased renal perfusion, you have continuous activation of the renin-angiotensin-aldosterone system, and, naturally, hyperaldosteronism. Less commonly, a tumor right inside the juxtaglomerular apparatus itself can cause overproduction of renin and secondary hyperaldosteronism. The diagnosis of these secondary conditions is oftentimes clinical, as in the case of CHF or cirrhosis, but can be confirmed in other cases by demonstrating elevated aldosterone and high plasma renin activity. Just like we saw in primary disease, all this extra aldosterone can lead to hypertension, in addition to hypokalemia and metabolic alkalosis. Treatment of secondary hyperaldosteronism is focused on treating the hypertension, which is most commonly done with aldosterone antagonists, such as spironolactone. All right, almost there. The next stop on this Wonka-esque tunnel of terror tour is the middle layer of the adrenal cortex, the zona fasciculata. This zone contains cells arranged in bundles or fascicles, kind of like the layers and layers of vertical trunks in this mysterious fascicular mushroom forest. These cells are responsible for the production of glucocorticoids, especially cortisol. Excess glucocorticoid production leads to Cushing's disease, or syndrome. We'll get to that. However, because there's so much awesome stuff to learn about Cushing's, we made a whole video on it, just for you. So check it out. Or don't. Just kind of spent all week on it. But yeah, it's fine. For now, we'll just focus on a few facts regarding excessive cortisol production driven by the adrenals themselves. Oh shit, what is that? Looks like some kind of primitive society of small moon faces beings. Cortisol, as you know, is symbolized by that eerie moon face, reminiscent of the moon faces that can occur with prolonged steroid exposure. In fact, that statue, some kind of moon deity, it would seem, embodies many of the clinical effects of chronically elevated cortisol, including progressive obesity and fat redistribution, skin atrophy and striae, glucose intolerance, muscle wasting, osteoporosis, and neuropsychiatric symptoms. Let's talk semantics for a sec. Cushing's disease is actually a specific subtype of Cushing's syndrome that involves an ACTH-producing pituitary tumor. Continuous ACTH stimulation of the adrenals leads to a cortisol overload. Cushing syndrome, on the other hand, is a blanket term for any condition that causes hypercortisolism. In this scene, the steroid overproduction is coming straight from the adrenals themselves. This adrenal-centric version of Cushing syndrome is almost always caused by a cortisol-producing adenoma, right there in the cortex. That plus sign on the explorer's adrenal cap should remind you of the ad in adenoma. And because this is a productive tumor pumping out steroids, we've turned up the light. Because the adenoma is producing cortisol autonomously, it's considered ACTH independent. It doesn't need stimulation from the pituitary, in other words. All that cortisol, in fact, exerts negative feedback on the hypothalamus and pituitary, resulting in low ACTH levels. Guess she was part of the film crew on this expedition, because there's our symbol for ACTH, that director's clapperboard. Again, we're talking increased cortisol, but decreased ACTH. So the clapperboard is broken. Without ACTH stimulation, the adrenal tissue around the tumor on the affected side, as well as the entire contralateral adrenal gland, get all hypofunctional and, over time, atrophy. We've illustrated this characteristic appearance in the foreground. Notice that the tissue around the tumor on the ipsilateral side, as well as the entire contralateral shroom, are all shriveled and sickly. This atrophy is in the zona fasciculata only, by the way, as that outer aldosterone-producing granulosa layer relies, instead, on the renin-angiotensin cascade for stimulation. Additionally, take a moment to imagine what the adrenals would look like in a patient with Cushing disease, which is driven by an ACTH-secreting tumor in the pituitary. In this scenario, both adrenals would be overstimulated by ACTH and thus undergo diffuse bilateral hyperplasia. We'll illustrate this distinction in our sketch that focuses solely on Cushing syndrome. So get excited. All right, more rarely, instead of an adenoma, it's actually an adrenal carcinoma, which can also be steroid secreting. These are differentiated by the anaplastic and dysplastic cell features on histology. Another rare form of adrenal Cushing syndrome is caused by nodular hyperplasia and hyperfunction of the entire zona fasciculata. Instead of just a localized adenoma, expect all the same results: high cortisol, low ACTH, and atrophy of the contralateral adrenal. Okay, we've made it this far. So I just gotta mention the innermost layer of the cortex, the zona reticularis. This region is responsible for the production of precursor androgens, such as DHEA and androstenedione. Excess androgen production by the reticularis is most commonly caused by congenital adrenal hyperplasia, a broad term used to describe a group of autosomal recessive diseases that arise due to a missing enzyme in the adrenal hormone synthesis pathway. These include 11-beta-hydroxylase deficiency, 17-hydroxylase deficiency, and 21-hydroxylase deficiency, all extensively covered in the previous sketch. So that wraps it up for our discussion on adrenal cortical hyperfunction. I want you to keep digging, though, because our next video takes place right at the center of the adrenal, the medulla. Why am I not going? I think those tiny mushroom people have chosen me as their supreme, omnipotent, godlike leader or something. No big deal. Oh, okay. I guess they're carrying me somewhere. Onwards, tiny mushroom slaves! I am a golden god. Fear me! I decree that every Thursday will be dedicated to binge-watching Strong Bad email episodes, because I am Supreme Leader Ricky and I have made it so. Disobey and thou shalt be smitten. Is it smitten? Smote? Or like smited? Someone help me out here.